My name is Dennis Cherian. I'm the Senior Director for Health and I work for World Vision. So I started my professional career in global public health and international development back in India. Soon after my graduation, I started working for World Vision, but prior to that I worked for a mission hospital. So I used to run mission hospitals. And I think it is fair to say that's probably what gave me the background interest and the motivation to understand the cultural dynamics of public health and healthcare seeking. And therefore, following my, and then I went for my master's in public health administration, following which I joined World Vision, and that is in 1997. And since then I have been working for USAID funded health projects, primarily in the area of infant young child feeding, child survival, and eventually I gained a lot of skills and experience in a broad spectrum of public health programs. So it is over 2 decades of work in international public health, and spread across the world. Asia, Africa, Latin America, and Middle East. I consider myself to be a development professional, but I think it is hard to distinguish between development and humanitarian, especially in today. I think in today's context, where, if I'm not mistaken, I don't have the statistics right, but roughly 40% of the world's population probably live in fragile humanitarian context. And so I think the fine line between these two are very thin, and therefore I think we need to talk more about whether these two contexts, what are the existing systems in place, whether we have strong systems. I think that's what distinguishes, perhaps to me at least, from what is humanitarian versus what is development context. And so I think I'm more of a development context person who has had experience working a lot in humanitarian context as well. There are extreme fragile humanitarian contexts. Maybe take cases like South Sudan, for example. But in any context, I think there are humanitarian contexts within an existing country. So the idea of an exclusive fragile context is not necessarily perhaps the right approach, but within a normal context of development, one can find fragile context. So, and I have had experience working in those kinds of contexts. But again, as I said, the distinguishing factors are probably factors of resilience, factors of strong health systems, and then safety maybe. Those are some of the thoughts that come to mind that we as professionals in this field need to take into account when even designing programs, for that matter. I started my professional work in public health through the US government Child Survival Project, and that has been a pioneering work where, if I'm not mistaken, that's the first project that USAID funded under child survival that was an integrated project that was integrated with health, WASH, microfinance, and a number of other community health initiatives. But then following that, I was able to do a number of pioneering work. And one pioneering work was the introduction of mobile technology for health in Afghanistan. It was pioneering from many fronts because it was the first time a technology solution was integrated as part of child survival initiative. It was a pioneering work because it was also the first time in 2008 that women in rural Afghanistan, women in Afghanistan use mobile technology. So I think it's not only an effort in transforming health outcomes, but also transforming social outcomes in terms of changing the social dynamics and importance of women in society, and also empowering women. Subsequently, pioneered work in integrated community case management for low literate community health workers in South Sudan. So this is all a background of some of the most important work I'm proud about. But I should say there are many projects, but one that comes to mind very recently is an adolescent health work in Uganda funded by the Dreams Initiative, an innovation grant where we introduced an early warning system coupled with school health committees. But the point is an early warning system that enables peer students to identify the risk factors of girls dropping out of school, girls under high risk for abuse and violence, and working together with local providers and communities to come up with ideas that would keep girls in school, prevent them from gender-based violence and HIV. So I'm very proud of that work. So the mobile technology work in Afghanistan was funded under the USAID's Child Survival Innovation Funds category, and we introduced it as an operations research piece. I brought in a partner called Dimagi at that time, and introduced an application and worked on refining and further advancing a technology solution called ComCare. So the work focused on prenatal and postnatal care, and also newborn. So what it would do is basically educate mothers on prenatal, postnatal, and also on newborn care. We were able to implement it for 18 months, and as a result of that, we had a control and an implementation side. And the results showed very promising outcomes. The work of that was pioneering work at that time, and then it was eventually scaled up to, for World Vision internally, to 16 countries around the world, the ComCare application and its various adaptations. The beauty is in our efforts to reinforce each other, in our ability to complement our work together. If you take community health systems, for example, I think that's where we add value, where our role in mobilizing communities, for example, community-based behavior change, or in responding to social determinants, issues of inclusion, exclusion. These are all strengths that non-government organizations and community-based organizations offer. And when we speak about health, governments are the providers of healthcare, and that's, at least that's the way we like to see ourselves. When we join hands together, we complement, and we help, in my opinion, healthcare facilities and governments do a better job. In other words, we are complementing resources, we are complementing our skills, we are complementing the gaps that they are unable to address, and this is a classic example of where the gaps of inability to mobilize communities and change the perceptions and behaviors, or build their confidence in the healthcare system, and that's what we offer. I mean, I have been with core group and this profession for the past 2+ decades, as I said, and I think the core group has evolved over the years in very dynamic ways, and I have been part of this for over 2 decades. I've seen the transformation. What comes to mind immediately and quickly is that core group still continues to be an important force in mobilizing, bringing people together who have a common purpose. And the common purpose, I think, is to make other people's life better. Thank you so much.